Welcome to the Explainer. Okay, let's dive right into how we can audit clinical trial methodologies and spot those sneaky mathematical errors. If you've ever read a medical journal or dug into the data for a brand new treatment, you've definitely seen a lot of complex math. But honestly, understanding that math is absolutely crucial. Why? Because it's literally the only language we have to separate cold, hard scientific fact from pure, random chance.
Imagine you're auditing a clinical trial. You need to know for sure if that fancy new drug truly works, or if the results are just, well, a mathematical illusion. And hey, this isn't just some boring academic exercise. Relying on flawed statistics means approving ineffective treatments, or even worse, missing out on actual, life-saving therapies. So today, we're going to arm you with the ultimate clinical auditor's toolkit. We'll show you exactly how to look at the structure of a study and instantly know if the researchers used the right mathematical lens to analyze their data.
So here's our agenda for building today's mental model. First, the clinical audit begins. Second, the rule of two. Third, the multiple comparison trap. Fourth, the ANOVA solution. And finally, dealing with skewed data. Let's jump in.
Section 1. The clinical audit begins.
You know, you can't use a screwdriver to hammer a nail, right? Well, you absolutely cannot use the wrong mathematical model on patient data. Analyzing continuous clinical variables, things like a patient's mean arterial blood pressure or serum cholesterol levels, requires choosing a statistical test based entirely on two things: the number of groups being compared and the independence of the data points. When an investigator evaluates a continuous outcome, they have to follow strict structural boundaries. So the entire audit process starts by simply counting the groups in the trial and asking one vital question: are these groups completely separate from each other?
Section 2. The rule of two. Okay, if you have exactly two distinct groups, the student's t-test is your go-to method. It's basically the classic statistical engine for comparison. But as an auditor, your job isn't done just by confirming there are two groups. Nope. You have to look at the actual individuals inside those groups. We have to ask, are these groups truly independent of each other? Because the specific type of t-test we deploy changes entirely based on that one answer.
This perfectly illustrates the difference. If the data points are paired in the exact same patients, you use a paired t-test. But if they're completely different people, you use an independent t-test. Let's say you've got one group receiving a new antihypertensive medication and an entirely separate, distinct group getting a placebo. That setup requires the independent two-sample t-test. But what if, say, you're measuring a patient's baseline hemoglobin level before starting iron supplementation, and then you measure that exact same patient's hemoglobin again 3 months later? Well, that data is dependent. It's paired to the exact same human body over a timeline. So for that, the paired t-test must be used instead.
By looking at the same patient over time, we effectively remove all that noisy person-to-person difference, which makes our statistical test incredibly powerful. I mean, think about it. Human bodies are vastly different. If I compare my blood pressure to yours, there are literally a million genetic and lifestyle variables at play. But if I compare my blood pressure today to my blood pressure tomorrow after taking a pill, the only major variable that's changed is the pill itself. The paired t-test isolates that internal variation, drastically increasing the study's power to spot the true effect of a treatment. It's brilliant.
Moving on to Section 3. The multiple comparison trap. So what happens when our trial expands to 3 independent arms, like, say, a high-dose drug group, a low-dose drug group, and a placebo control group? You might be thinking, hey, I'll just run a t-test between every possible pair. Actually, scratch that. This is a frequent, honestly catastrophic mistake that pops up all the time when auditing studies, and it's a highly tested concept on medical board exams for a very good reason. Running multiple separate t-tests for 3 or more groups completely destroys the structural validity of the math. It is strictly forbidden.
5%. That's the standard threshold for statistical significance, meaning we accept a small 5% probability that our findings are just due to random chance. In clinical research, a p-value of less than 0.05 is the absolute gold standard. It basically means we're 95% confident the drug worked, and we're willing to accept a 5% margin of error. But here's the catch. That 5% limit, it only applies to a single test. And here is where the math traps researchers. If we run multiple individual t-tests, we exponentially inflate the overall type 1 error rate far beyond our safe 5% threshold. Now, a type 1 error is a false positive. It's essentially telling a patient a useless drug will cure them. Not good. If you run 3 separate t-tests for your 3 study arms, the math compounds.
You aren't just taking a 5% risk anymore. Your overall probability of falsely claiming a statistically significant difference skyrockets purely by random chance. You're basically playing statistical roulette. To prevent this compounding error, the entire statistical approach has to change. Which brings us to Section 4, the ANOVA solution. To prevent this compounding false positive error, investigators must use an incredibly elegant mathematical solution, ANOVA, which stands for Analysis of Variance. A one-way ANOVA looks at all the groups, the high dose, the low dose, and the placebo at the exact same time. It mathematically evaluates the variance between the different groupings relative to the variance within each specific group. This yields a single comprehensive probability value for the entire system, without inflating that overall error rate. It's like looking at the whole system from a bird's eye view, telling you if there's any statistically significant difference anywhere in the room. But here's the thing. If the ANOVA yields a statistically significant result, it only proves that at least one group mean is different. It doesn't specify which exact pairs differ. So, is the high dose different from the placebo? Or is the high dose different from the low dose? To find out, we must follow these steps and deploy post hoc pairwise comparison tests to pinpoint exactly where the difference is. A great example is the Toolkit honest significant difference test. These specific tests mathematically adjust that significance threshold we talked about earlier. They safely isolate the true differences between the specific groups without letting that false positive, type 1 error rate inflate. It's your mathematical safety net.
Finally, Section 5, dealing with skewed data.
Now let's explore the escape hatch. What do we do when the data just doesn't play by the rules? You see, every standard t-test and ANOVA relies on parametric assumptions, meaning they demand that the continuous data follows a beautiful, clean, symmetrical normal distribution bell curve and possesses relatively equal variances across all groups. But what if the clinical data is heavily skewed by a few extreme outliers, or the sample size is exceptionally small? Well, applying a standard t-test breaks the math. Those parametric assumptions fail entirely. Your clinical audit should instantly flag this as invalid, forcing researchers to shift to non-parametric alternatives.
And this translation matrix right here is your ultimate failsafe. If the data is skewed, you simply swap the parametric test on the left for the non-parametric alternative on the right. If a study compares a skewed continuous outcome across two independent groups, they have to abandon the independent t-test and replace it with the Mann-Whitney U-test, which is also known as the Wilcoxon-Rank sum test. If the data is paired, like our before and after iron supplement patients, but it's skewed, they drop the pair t-test in favor of the Wilcoxon-Signed-Rank test. And lastly, if researchers need to compare a non-normally distributed continuous variable across 3 or more independent groups, the ANOVA goes straight out the window and the Kruskal-Wallis test is deployed. These non-parametric tests are genuinely brilliant because they evaluate the data points by their ranks from lowest to highest rather than analyzing raw means. This completely negates the chaotic pull of extreme outliers.
As you can see with this board example, mastering these specific structural boundaries isn't just some abstract theory. It's a vital, highly testable clinical skill that allows a clinician to audit a study's methodology instantly. Whether you're identifying that an independent t-test is required for continuous data between two unrelated groups or swapping to a non-parametric test, the core logic remains exactly the same. You map the number of groups, check for data independence, confirm the data's distribution curve, and boom, the correct mathematical test reveals itself perfectly.
So, here's my question for you. Will you be able to successfully audit the methodology in the next clinical trial you read? Or will a compounding type 1 error trick you into prescribing a totally useless drug? The next time you see a clinical trial boasting incredible results across multiple patient groups, look closely at the math, because your patient's health literally depends on it. Mastering these boundaries ensures the mathematical model aligns perfectly with the underlying distribution of the patient data. You're no longer just blindly reading the abstract, you've got the toolkit to audit the truth. Thanks so much for joining me on this explainer. Keep questioning the data and stay focused.